And can everybody see my screen?
Yes.
All right. Cool. I think that looks good. Hi, everybody. I'm Alicia Vincent. I'm a third year, well, actually not anymore. I just finished my final year of my small animal internal medicine residency at Michigan State as of Tuesday. So I'm officially free. I'm going to be talking to you guys today about canine pyelonephritis. I must admit that I probably will not be as eloquent or experienced as our previous presenters, but what I lack in talent, I make up for in bad jokes and a genuine love for the kidney. So with that, we will get started then. So the paper that we're talking about today is, I guess, in the grand scheme of things, a little bit older, being that it's from 2018, but this was really the most recent paper that I could find that detailed pyelonephritis in the dog, or really in the cat too. And I thought it was a good paper. It is a retrospective study, but I do think that it added valuable information, certainly to my knowledge base, and I think to the knowledge base that we have presently for pyelonephritis. So the objectives, as stated by the authors, were to evaluate prevalence of pyelonephritis in dogs presenting to referral centers, and these were 3 academic referral centers in Canada. They also set out to describe clinical signs, diagnostic results in these dogs, and to identify any concurrent disorders to determine potential risk factors for pyelonephritis in these dogs. And so the way they did this was, as I had said previously, a retrospective case series looking at the medical records for these patients, as well as histopath of the kidneys, which was done by one of the authors. So I thought that their introduction was good. It was succinct, but in the typical JBIM style. But I think it really pointed out that there is a paucity of information about pyelonephritis in the veterinary literature. I always like to start with definitions. So the way that they define pyelonephritis in this paper would be inflammation of the renal pelvis plus or minus the parenchyma. They comment that ascending bacterial infections are more common than hematogenous bacterial spread, which I think is fairly well substantiated by the rest of the literature that we do have. They go on to talk a little bit about acute, subacute, and then chronic courses of infection. And in the context of this paper, that's based on the histopath, not necessarily the clinical presentation. And that does get a little bit confusing as we get into the discussion, and certainly was a cause of confusion for me in reviewing some other papers talking about pyelonephritis. It seems as though there's not really a good general consensus on sort of the clinical distinctions between acute, subacute, and chronic, although distinctions have been made from a histopath standpoint. And so the diagnosis historically is going to be based on our clinical signs, UA findings, a culture, perhaps imaging, and then response to therapy. And one of the things that's challenging too, I think, is trying to establish what we would consider to be a gold standard for diagnosis of pyelonephritis. And the authors do go on to talk about that later in the discussion, but we'll find out later that that also is a bit of a point of contention, not only in the veterinary literature, but also actually in the human literature too. And they do, of course, comment that ideally we would have a positive culture directly from the renal pelvis or a positive culture on tissue biopsy sample. So for these dogs, the diagnosis of pyelonephritis required a histologic diagnosis, which was either based on a necropsy diagnosis or a renal biopsy. They went on to describe, I thought, fairly nicely what they were looking for from a histopath standpoint. And then they scored these lesions based on stage, activity, and severity. And for their medical record review, they were looking at signalment, presenting a complaint, the clinical signs and duration to the best of their ability to get that information, any sort of previous medical treatment, and then a minimum database when available, imaging findings when available, and then urine culture when available. Stats, admittedly, I am not a trained statistician, and so this is my least favorite part of going over things in Journal Club, but on kind of the 10,000 foot view, it looked like their statistical analysis was appropriate. Certainly there's folks on this call that are much better equipped to make that determination than myself, so if anybody has any any glaring objections to this, please do jump in. So moving on to the results. They had 47 dogs that met the inclusion criteria. 12 of these dogs had renal biopsies, 11 of which were via nephrectomy, so good Lord, hopefully that was for the right reason. The rest of these dogs were post-mortem samples, and then we go on to look at their demographics. So in general, most of these dogs were greater than 7 years of age. Not surprisingly, about 70% of them were females. And then as far as breed distribution, the one thing that popped out to me was the Shelties, and knowing that these dogs, many of them were post-mortem samples, I wondered about the incidence of TCC in these guys, and we can go into that a little bit further as we move on through their results. Also, feel free to jump in with anything if anybody has any thoughts or concerns. It looks like the chat function is open on mine, but I don't know if it's going to work. We'll find out. Okay, so for clinical findings, the median duration of clinical signs was quite variable, and that certainly could fit with having a spectrum of dogs, right? So from acute to these subacute to these chronic cases, and so that would fit, I suppose, but it just seemed like a really wide duration of clinical signs. Only 8 of these guys showed only lower urinary tract signs, which the authors defined as hematuria, plaquuria, stranguria, periuria, or dysuria. They went on to define upper urinary tract signs as fever, lumbar pain, abdominal pain, PUPD. And then another sort of interesting point is that incontinence as a clinical sign was either classified into upper or lower urinary tract signs based on whether it was attributable to overflow incontinence, neuro or anatomic disease, plaquuria. So sort of fell into both categories. And so for me, when I am teaching students, pyelonephritis is certainly a tricky one because I think that there's a lot of dogma about what the classic clinical signs and a lot of the classic clinical pathology findings are. And I know that for me as a student, you know, I was taught that these animals are febrile, they have back pain, they're uncomfortable, they may be anorexic, that they're sick animals, at least in the context of certainly the acute cases. And to be quite honest, I'm not sure that we had much, if any, sort of training about looking for chronic pyelonephritis when I was a student. And so I thought it was interesting looking at sort of the distribution of these clinical signs in this particular study. And as you can see, only 21% of these dogs were febrile. Not a lot of them had back pain. Anorexia and hyporexia was more represented, but certainly not what you would have been led to believe, or not what I was led to believe as a student, at least. Predisposing factors. So 75% of these dogs did have other diseases as well. The authors go on to describe kind of in in detail what these different factors were. And I think that, again, we do assume that uncomplicated pyelonephritis, at least in both the author's description and in my limited lit search, to my knowledge, hasn't been described in dogs in the veterinary literature. And so probably a lot of these animals do have some sort of predisposing factor or concurrent disease. The pyelonephritis as a cause of sepsis in 5 of these dogs based on necropsy I thought was interesting, mostly because we actually happened to have a case on the clinic floor just before I finished up my residency, which was a fantastic example of this. And I will go on to show you a little bit about that case just because it was cool. So we had a 4-year-old intact female English bulldog that was referred to us from the family vet for azotemia, vomiting, nephrolithiasis, and ureteroliths noted on abdominal radiographs. And these were her ultrasound images. So the right kidney, you can see that there's this sort of mixed echogenicity subcapsular fluid, not a happy kidney. And then this is kind of distal ureter here on the right ureter, and there was a large ureterolith that measured, as you can see, about 1.7 centimeters on ultrasound. And let's see if this video will play, just because it was so cool to see basically subcapsular pus, which I had not ever seen before, and the radiologist was pretty psyched about it too. And then we were foolish enough to think that we could maybe stent this ureter. And so this was our fluoro study while we were attempting to pass the guide wire up this ureter. And I don't know if it's just me, but bulldog ureters are insane. And certainly if anybody else shares that experience, I would love to hear it. So this dog ended up going to surgery for a ureterotomy to remove that stone. And you can see a pretty unhappy ureter here, and then the stone. And then the best part of this, and I'll speed this video up for you guys, but for anybody that likes watching abscess videos or anything of that nature, this was crazy. Actually birthing this stone out of the ureter. And for anybody who was wondering, yes, it was a struvite stone predominantly. Totally crazy. Okay, so moving on to ClinPath findings. This is another area that I think tends to be a hang up for students, certainly when I'm going through pyelonephritis with them, and was a hang up for me as well as a student, is that not all of these dogs are azotemic. And certainly that would make sense, right? Especially in some of our cases where it may only be unilateral pyelonephritis in an animal that has otherwise underlying normal kidneys, or the other kidney at least. 14% of these dogs had a quiet urine sediment, and 20% of the dogs that did have pyuria didn't have clinical signs. So I think it's really hard to establish what the definitive ClinPath findings are for a dog with pyelonephritis, because we see this variety of clinical signs and a variety of presentations. And again, just to sort of highlight that, sure, 64% of these dogs had pyuria, but the rest of them didn't. 68% of them had bacteriuria, but the rest of them didn't. And that tends to be a point of frustration for a lot of our students who expect that these animals that come in are going to have pyuria, they're going to have bacteria, they're going to have a very active urine sediment, and that just is not the case in all of these patients. So ultrasound evidence of pyelonephritis. This I think was another sort of interesting finding for me. Hold on, there we go. So 2 of these dogs had completely normal ultrasounds, and in 72% we saw ultrasound evidence of pyelonephritis, but again, in the rest of them we didn't. And so I think that when you're trying to build your case for whether or not this dog has pyelonephritis, it just lends a bit more support to the idea that it's a case that probably should be built on a number of different findings, you know, historical, physical exam findings, ClinPath imaging. It's not going to be an easy sort of one and done as far as diagnostic testing that you can do for these animals. And oh, my little box didn't pop up, but I did want to just highlight pylectasia as a sign of pyelonephritis, and kind of specifically talking about another study that has been brought up twice now in this journal club of the overlap in the degree of pylectasia between pyelonephritis cases and ureteral obstructions and CKD patients, and how the number itself, or I guess the degree of pylectasia itself, is not something that can be used as a standalone to say, yes, this animal is obstructed, yes, this animal has CKD, yes, this animal has pyelonephritis, with, I suppose, the exception of, you know, these pelvises that are greater than, what is it, the 12 or 13 millimeters, that those are obstructed until proven otherwise, and that this really does probably live on a spectrum. So this is another one that's a little bit of a doozy for me and for students, I suppose, is that your bacterial urine culture results, again, not going to be positive in all of these cases. And so when we're thinking about these cases, again, and we'll get into it a little bit later about the validity of your urine culture obtained from the urinary bladder versus one that's obtained from the renal pelvis itself, et cetera, et cetera. And not surprisingly, the most common pathogen being E. coli. I think that fits pretty well with what's been published previously, and with the idea that many of these are going to be ascending infections. So I guess the other take-home point here is, again, so pyelonephritis is not always bilateral. It certainly can be unilateral, and maybe in more cases than I even had expected. So 28% of these dogs being unilateral. That was an interesting finding for me, at least. And then moving into their overall results. So they did not find bacteria at all in 15 of these dogs on either the urine sediment exam, culture, or histopathology. That was a little bit bothersome to me, because earlier in their discussion, they talk about using a positive urine culture from either the renal pelvis or from the actual renal tissue as the gold standard, quote unquote, for diagnosing pyelonephritis. And yet in 15 of these dogs, there was no bacteria present. They do go on to explain that in several of these cases, the animals were already receiving antibiotics, or they didn't have an appropriate or a complete diagnostic workup done antemortem. So they were stuck with basically making this diagnosis based on histopath. And then they also comment that in human studies, there are some papers that would demonstrate that urine often contains bacteria that's not actually detectable using routine bacterial culture and isolation. And certainly we can think about, you know, would we miss mycoplasma and things of that nature, Corynebacterium potentially as well. But then also talking about, is there potentially a role for using fish to look for bacteria in these samples that we're not going to catch on our routine culture. And I thought that raised an interesting point. So the other kind of take-home points from their discussion, or rather from their results, the fever being significantly associated with histologically subacute pyelonephritis. I think that's again, like I said, a hang up for a lot of clinicians is, you know, if this animal has pyelonephritis, shouldn't it be painful? Shouldn't it be febrile? Shouldn't it have an inflammatory leukogram, et cetera, et cetera? And the take-home message is, well, maybe not. Probably the most interesting finding for me from their results was that, and I'd be curious to know from the authors kind of how they arrived at this conclusion, but that pyelonephritis was not suspected by the clinician on the case in 45% of these cases. Now, I don't know what everybody else's sort of clinical impression is, but I actually think that we probably overdiagnosed pyelonephritis in our hospital, at least in my time, my 3 years at MSU. But this would suggest that maybe we're actually missing these cases. I don't know if anybody else wants to jump in and comment. Do you think that we're missing these cases? Do you agree that these are cases that clinicians are potentially missing?
I agree with you. At tough, I feel like we're probably overdiagnosing it.
Yeah. Yeah, that's certainly been my impression. And again, perhaps we're, and I guess I would say overdiagnosing it in our AKI patients. I think that pretty much we have a lot of dogs that come through the clinic floor that have an AKI, and I think a lot of them end up with a diagnosis of pyelonephritis that I'm not totally convinced that that's the cause of their AKI. And you know, perhaps they do improve on fluid therapy and antibiotics, but I don't think that we do quite a good enough job of a diagnostic workup to arrive at that conclusion. So their discussion really focused on kind of the overall prevalence of pyelonephritis, again, touching on these predisposing factors, revisiting some of these sort of quote unquote classical clinical signs. Again, the things that are going to get taught in your vet school lectures, the things that are going to end up in textbooks. And then broaching the subject of looking at fish and other sort of diagnostic entities beyond our routine bacterial culture and isolation. And I thought it was a really nice discussion. I actually really liked the way that it read. So clinical pearls, what's the take-home message? For me, it sort of reaffirmed the idea that pyelonephritis is hard to diagnose, hard to rule out. And kind of despite this, the overall prevalence seems to be low. And again, for me, thinking that we probably are overdiagnosing it, at least in my clinical experience, which admittedly is limited, but certainly something to think about. And then the last thing I wanted to touch on just before I kind of open the floor up for discussion is what's in the textbooks. So again, this is me coming out of an academic residency where student teaching was a large focus of what we did. And so when I'm sending my students out to do their own research, kind of the first places that they're going to look are either going to be, you know, Merck manual online. If I can really push them, maybe I can get them to look at current veterinary therapy. And maybe the really good students, I can push them enough to look at Ettinger. But the interesting thing, and I did briefly just kind of run through those sources, as well as the nephrology and urology book by Dr. Barges, there's not a ton of information in any of those texts about pyelonephritis. CBT has a couple of paragraphs. Same sort of thing for the nephrology urology book. There's a short chapter on it in Ettinger, but there's some dogma in that as well, which I think is maybe not maybe something that's worth challenging. And the points that I pulled out of Ettinger, at least, that I was a little bit questioning are what I've got on the screen here. And so certainly the first point about if left untreated, bacterial pyelonephritis will give rise to permanent and progressive damage of the involved kidney. That's definitely been challenged in the human literature. It's been challenged in the veterinary literature as well. And the citation for that is missing. So certainly something to think about. I don't know if this is the right time to get into it, but how we treat or how we address our highly suspected pyelonephritis patients in the hospital, as far as antimicrobic selection, I think is, like I said, could be a topic in and of itself. But ampicillin and really a beta-lactam would not be my first choice if I truly thought that this patient had a bacterial pyelonephritis. And that it wasn't something, you know, like lepto, et cetera, et cetera. And then they comment on using a urinalysis to assess response to therapy rather than a urine culture, which is, again, I think something that many of us might take objection to as far as a monitoring tool. And then finally, the comment about chronic kidney disease being considered both the origin as well as a sequelae to pyelonephritis. That too has been challenged both in human and veterinary literature. So these are things that are written with reasonable confidence in these textbooks, and this is where I'm sending my students to read and find additional information. And then this is also, you know, what those of us who are studying for a boards exam a year from now are having to read and look at and consider. So I just thought that was interesting. And then finally, future directions. So this of course is a study out of just 3 institutions and geographically all within Canada. So might be nice to see a sort of similar multi-center study looking at a couple of geographic locations. Makes me wonder if we should be a little bit more aggressive about pilocentesis, you know, plus or minus renal biopsy. I certainly don't think that I'm convinced that I need to be biopsying any dog that I think has pyelonephritis, but based on the paper out of JAVMA 2019, Dr. I'm going to butcher this, Adedali, and then Reitz and JD's paper. I certainly feel more confident about doing pilocentesis, ultrasound-guided pilocentesis in these dogs to try to get a sample. And then finally, kind of what role should diagnostics such as FISH play in our workup of these cases, and is there a place for those diagnostics? So Dr. Vaden says, it's hard to assess prevalence based on this study because they required tissue. Yeah, I definitely agree with that, and certainly would be one of the limitations for this as far as extrapolating that information to our general populations. So sorry I kind of breezed through that, but thoughts, hopes, dreams, comments? So Dr. James says, I think overflow incontinence is not from PUPD, it's from obstruction. Yeah, I definitely think that that's a reasonable thought. Just out of curiosity, is anybody, or I guess, because this is a source of somewhat frustration for us on the medicine service, but we frequently will get patients transferred to us from the ER service that the working diagnosis is bacterial pyelonephritis, and the antimicrobic choice is something like Unison. Do you guys see that your ER is sending them to you on something like a fluoroquinolone, or do you get them sent over to you on a beta-lactam as well?
I feel like at Tufts, the ER will commonly send them with, we get transferred with, Unison or just ampicillin. But I'd say rarely, clinician dependent, but rarely is it a fluoroquinolone.
Okay. Yeah, and Dr. Cook comments mostly on Unison, likely due to concerns about lepto. Totally agree from the lepto standpoint, but we've got some that'll come in that are lepto negative on PCR, plus or minus witness testing, plus or minus they'll have lepto titers pending, and so they feel fairly good that it is not lepto, that it is a bacterial pyelonephritis, and we still get them on ampicillin or Unison. Any other thoughts?
Oh, I just want to end with one little digression from what you said, little controversy. I would say that we don't know if pyelonephritis is going to cause damage to the kidney or not. So I agree with that. But I think that we have to be careful in assuming it doesn't. There's definitely studies in people that, especially in children, that show that it does. And in those children, it might be the actual reverse jetting that's causing the damage. But nonetheless, there is definitely damage, and that these kids that have chronic or have urinary tract infections early in life have a higher incidence of chronic kidney disease later in life. And so it could be how you develop or what mechanisms lead you to develop the pyelonephritis that sets you up for chronic kidney disease. But I just think as a profession, we have to be real careful in assuming it doesn't cause damage.
Absolutely, I definitely agree with that, and I guess I should be cautious to say yes. I would never suggest that we don't treat these. More so, just sort of an interesting thought about, you know, how much damage does it cause, and does it cause irreversible damage in every patient? And I think that's the question mark. Dr. Cook says, I have routinely stopped antibiotics if urine culture is negative and lepto is negative, assuming no overt bacteria in AKI cases. What is everyone else doing?
So for me, a lot of the time the lepto titers are still pending, and they could, so we still are getting the convalescent titers, which will determine if they actually have lepto. So sometimes, depending on the case, how likely I think it is they have lepto, I will do a 2-week course of doxycycline, or if the patient can handle it if they're eating.
Dr. James says, they said hematuria is a lower tract sign. I think we see pyelo with hematuria. I think it's an either or sign. And she also comments that, also, I wonder how many people think they have spread lower bacteria to upper with expression in neurodogs due to urine heading back up the ureter. Seems rare to me. One case I can recall. Anyone else? Not actually something that I've thought about before, but a reasonable thought.
I don't know if people remember, I want to say it was 2 years ago at ACVIM when we had the external person come in to talk about bacteriuria. She was from Ohio area. At any rate, she said that there's good evidence that's starting to mount that bacteria prefer either the kidney or the bladder, but that at least a population of them don't go to both places. So I thought that was really interesting too. And I think that kind of helps explain why some of us have had negative cultures from a cysto, but positive cultures from a ureteral catheterization. And so again, there's, a lot of dogma that we've lived with and accepted about pyelonephritis over the years that I just think we need more information. And probably one of the first things that we need in order to start getting that information is a really good way to a minimally invasive or maybe non-invasive way to actually identify which cases have pyelonephritis. Because I agree that pilocytosis is the best, perhaps the best way, but it can be hard to get owners on board with a lot of those as well.
For sure. And the other challenge for us at least, or somewhat of a unique challenge, being that we've not had radiologists at MSU for a couple of years now, is who's going to do it and who's going to be bold enough to poke that kidney, or rather to poke that renal pelvis. Certainly if it's a marked piloectasia, then I think we'd feel more comfortable with it. But I'm not going to be the one going after a 3 or 4 millimeter pelvis. I'm definitely not bold enough. Any other last minute thoughts? Well, that was everything from me. I appreciate everybody listening to me and contributing and not making me have to talk for the entire hour. Very appreciated. And thanks everyone for joining then.
Thank you.
Great discussion, everybody. I think these last few weeks, we've really seen that we're getting some really good discussions and participation in journal clubs. It's really refreshing. Nice job, Alyssa.
Thank you.
Thank you.